Hello, everyone. My name is Antu Hossain, the Global Health Impact Officer here at CanWatch, the Canadian Partnership for Women and Children's Health, and my pronouns are she and her. I would like to thank you all and welcome you all to this space for this learning opportunity today entitled Reuse and Recycle, Practical Guidance on Maximizing Existing Data. Thank you all for joining from across different locations and hopefully in the comforts of your home. For me, home is Toronto, or known as Takaranto, and I am grateful for the stewards of the land who have made it possible for a settler like myself to live, work, and learn on the traditional lands of the Haudenosaunee, Wendat, and most recently, the Mississaugas of the Credit. Guided by our members, CanWatch found a gap in measurement innovation. We wanted to conceive a space to tackle the challenges of process, partnerships, and room for creative problem solving with respect to data, monitoring, and evaluation. And as such, the Canadian Collaborative for Global Health was initiated by CanWatch with the generous support from Global Affairs Canada. So 6 different labs or project teams of diverse partners across academic, research, civil society, implementation partners embarked on an investigative inquiry to address urgent data challenges in global health and gender equality. All labs included these partnerships for mutual strengthening of capacity. Since then, our world has drastically shifted, making it more pressing to foster innovation and knowledge exchange in data sharing practices. 2 of these labs, I am thrilled to say, are represented here today on our call in this critical dialogue. And as you can see, their valuable work encompasses the strengths of multiple global health partnerships on the slide here. We will be leveraging their expertise today and knowledge to have a broader discussion on best practices and opportunities for reusing existing data. Our discussions will be grounding their presentation to introduce a common language of what is existing data, what are the sources of it, and how can NGOs and partners navigate the advantages and challenges of their uptake. After their presentation, we will move into an open discussion where we encourage the audience to share their reflections. We truly want this to be, in fact, a dialogue. We very much encourage you to, at that point in time, to raise your hand using the Zoom feature, where you may at that point unmute yourself. Or throughout the webinar, you may add your questions into the chat box, at which point we will also be taking questions there. A few housekeeping items. As you can see, the webinar is being recorded and it will be made available on our website. If you are having any technical difficulty throughout the webinar, please write a message to Tina La Rochelle. Her brackets there say technical support. And so without further ado, I would like to introduce our amazing panelists today. We have Dr. Peter Berti, who is a nutrition advisor at HealthBridge Foundation of Canada, a position he has held for 22 years. A focus of his work has been monitoring and evaluation of food systems and health system interventions. After working for many years with farming communities, Peter himself became a farmer and is now a certified organic farmer, growing vegetables in Smith Falls, Ontario. That's awesome, Peter. Milena Nardocci has a nutrition degree from the University of Sao Paulo, Brazil, and a master's in public health from the University de Montreal. Her experience and research interests include quantitative research, public health nutrition, chronic disease prevention, and maternal and child health. She works at Transnut, a WHO collaborating center on nutrition changes and development. Nice to have you with us, Milena. And lastly, we have Dr. Ties Boerma. He is the University of Manitoba's Canada Research Chair in Population and Global Health. He's formerly the head of health statistics for the World Health Organization. Dr. Boerma has over 20 years of experience working in public health and research programs in developing countries. And currently, he is the director of the International Countdown to 2030 for women's, children's, and adolescents' health. It's really nice to have you all with us here today. I will let them go on with their presentations. So over to you, Peter, to share your presentation.
Thanks. So I'm going to just quickly talk about what we did in the lab, and so that we can spend most of the time talking about what the implications are, what it means, and not. I know many of you were at the previous webinar and are already familiar with the results. So I'll just give a quick overview. If you next slide there, Milena. So this is the results. This slide will be up throughout the time that I'm talking, so you can take a good look at it. So what we did for our work, we gathered NGO baseline reports from MNCH projects, 46 of these reports, mostly Canadian, also some Vietnamese NGOs working in MNCH. And we extracted all the indicators in their baseline reports. Then, extracted all the estimates of the indicators. On average, there was over 100 indicators with estimates per report. Then we matched these estimates in these NGO reports with the closest, with a matched indicator from DHS or MICS, so Demographic Health Services, and multiple indicator cluster surveys from USAID and UNICEF, respectively, who have massive amounts of data publicly available. Match the data set from DHS or MICS as closely as possible for geographic location and for year. And then we matched the indicators and subtracted the NGO estimate from the DHS or MICS estimate. So we had almost 2,000 of these matched pairs of estimates. So for example, in the box plot on the slide there, under stunting, so that will be, some NGOs will have stunting of under 2s, and sometimes they'll report under 2s and 2 to 5 years and so on. So all those different estimates were matched with the estimates calculated from the DHS or mixed data set. So say in the one NGO report, they estimated the stunting for the 2 to 5 year olds was 40%, and DHS for that same country working in the same region calculated 45%. So then 45 minus 40 is 5. So that would be graphed at +5 on this box plot. So this is repeated for all the indicators that we had for all those 2,000 matched pairs, and developed these box plots showing the difference, the range of differences between DHS and mixed estimates and NGO estimates. There are about 25 or so categories of indicators. Each one of those will be made up of between 1 and maybe 10 specific indicators. Like woman able to read is woman able to read, but stunting is made up of all the different age groups with the stunting subgroup. So you'll see that sometimes estimates are close, sometimes they're almost equal. There is a correlation between NGO and DHS or mixed estimates, but not a perfect correlation, and sometimes they're quite different. You see sometimes those extreme values up to 50, 60% or minus 60% difference between the two. Very few indicators have all of the observations, all of the differences within, say, 5 or 10% or even 20%. So then we want to think about what that means if an NGO would like to use DHS or mixed data instead of doing their own baseline data collection. The differences between NGO and I'm just going to say DHS, and it means DHS mix instead of, okay. So the differences between NGO and DHS, some of it is explained by how closely the surveys were in the geographic location. A small amount of it was explained by the number of years difference between the NGO and the DHS survey, right? Because DHS or mix might only be every 5 or 10 years. They might not necessarily be within the same year, even the same 2 or 3 years that the NGO's data were collected. But that only explains a small amount of the variation. Most of it is random, unexplainable. We don't have a specific reason why they're not getting the same estimates. So note that we're not saying, this is not that the DHS and mix have it right and the NGOs have it wrong, and this is a measure of how wrong they are. Rather, they're both wrong, right? They're both providing estimates of some reality, which we don't know what that reality really is, They both provide estimates of that reality. They both are wrong by some unknown amount. So the question then isn't, why should an NGO do a survey and be so wrong? But rather, should an NGO do a survey committing all that time and resources when they could get similar-ish information for free, or almost for free, right? You do need to spend some resources in extracting and analyzing the data, but a very small percentage of what doing a whole survey would cost. So so that, I think, is where we kind of leave this. What do we think? How do we think about using NGO DHS or mixed data, and how good is good enough for the NGO? One other point then, I'll answer that question that just popped up. No, unless unless the question was, were they adjusted for things like education level? If the NGO was estimated things like women received A and C by education level and estimated those, then we would do the same. But so it wasn't a statistical adjustment, just a grouping according to the sampling universe that the NGO was trying to capture. And one last point I'll make is that, as I said, the NGOs tend, on an average baseline report, would have over 100 estimates, but not all those things are available in DHS. We matched on average 18 estimates from each baseline report. Should I answer that other question that popped up? Or okay, so I think it said, when the NGOs be targeting communities with poorer health outcomes. That's yes, that's usually something that NGOs are trying to do. I think, though, they don't actually get the poorest of the poor, because the poorest of the poor are so hard to reach and expensive, and they have some pressure to put up some numbers. So it's probably like it's the second poorest of the poor. But anyway, aside from that, there could be, that could explain some of the difference. But if that was the case, if DHS was representative of the entire population and NGO was representative of a poorer subgroup, then you would expect that for the indicators that are of good things, that the DHS would always be higher, and of things like stunting, the NGO would always be lower. But that's not the case, right? So with the DHS, they provide national estimates as well as regional, provincial, sometimes sub-provincial estimates. And so we're able to match at that level, which would control, I think, for some of those regional disparities in wealth. Not all of it, but okay, I should stop talking. We can talk more about that. But the answer is, you would think so, but no. So I'll turn that over to Milena now.
So, hi everyone. We thought it would be interesting to give a quick overview of some public available data and where and how you can access them. And I'll be talking about the DHS and the MICS, which are population-based health surveys, as Peter said. They provide data for over 90 countries, and you can find thousands of indicators related to maternal, child health, and much more. As you saw in the previous slide, some examples of indicators that we worked with using DHS. I'll be talking specifically about DHS, but most of the things that I talk about also applies to MICS. So both DHS and MICS are available online on request and for free. So if you want to download the data, you have to request access, but this is something very simple. You just have to briefly explain how you plan to use the data, and they often reply like within 24 hours. And the DHS, they have something called the stat compiler, which is an online tool that you can use to create frequency tables, graphs, and maps. And these tools specifically, you don't need to request access, so it's available to everyone. And if you are considering to work with DHS, I think the stat compiler is a good place to start, because you have access to most of the data that's available on DHS, and you can have a good idea of types of indicators available and also for which countries and years. And the tables and graphs you create with the stat compiler, they use harmonized data, which means that the data is comparable across countries and years, which is really nice. And one thing to think about is that the stat compiler, they only provide point estimates. So if you think, I think for 2 indicators, they might have the confidence intervals, but for most indicators, you won't have access to it. So it's just the point estimate. So if you plan to calculate confidence intervals or standard errors, you have to download the data. And you, with the stat compiler, you can obtain the indicators stratified by region, by age group, and other variables, but you have no control over the age groupings, for instance, so you're limited to what is available in the stat compiler. One advantage of the stat compiler is that you don't need any special analysis skill to use it, which is great. It's an online point and click, and it's very user-friendly. Now, if you want to perform more like customized analysis, you have to download the data. And for that, once you have the data, you can do whatever you would do. Like, it's much easier to work with the data. So you can calculate standard errors, confidence intervals, and perform any kind of significance testing if you would like. But it will require some more advanced skills for that. But honestly, I don't think the skills that you would need to work with DHS and mix would be something more than the skills you would need to analyze data from, for instance, an NGO survey. I actually think it might be easier because DHS and mix, they provide the data that it's already clean, it's very organized, they provide all the documentation you need to get familiar and to analyze the data. They also provide the sampling weights and other variables to take into account the complex sampling methods employed in the survey. And I added here some links that I think Antu already shared with everyone. If you want to know more about DHS, how to work with the data, I highly recommend. They have all kinds of documentations. If you're just starting, the DHS YouTube channel is really great to start, just to get an overview of how the data is sampled and how to analyze it and how the data is organized as well.
Thanks, Peter and Milena. I think that's great. So I think it's a wonderful piece of work and very informative. So I'm going to share a few thoughts with you for discussion based on what we just heard. And this is from a related lab. We focus very much on surveys in adolescent sexual and reproductive health, working with Manitoba University, obviously, and Countdown, but also Africa Population Health Research Center and National Institute for Medical Research in Mwanza. So if we think about monitoring, learning, and evaluation in the context of NGO projects, so we have to take the context into account. So often NGO projects are in a difficult setting, remote or most disadvantaged populations. There are generally limited data for the target population specifically or a district as a whole. The projects themselves have usually short timelines, 3 to 5 years. And if we look at the resources, I mean, it may be a serious investment of several millions of dollars, but if you compute it per capita, every adolescent or every woman, it often translates into, a few dollars per year, not more than that. So I always say a cup of tea and a few chapatis, and that's it. So we have to, when we think about impact, we have to be modest. At the same time, there's demand for results and accountability from donors, and perhaps less so from country governments. So the implications of that are that it requires a major investment to obtain data from the target populations to get the reliable indicators. But it's important for project design, implementation, and possibly for monitoring and evaluation. One needs to have something that's quick and efficient to implement, because if one embarks on a big baseline survey, those things take a year from design to really final results. And then the impact expectation should probably be more proportional to what the per capita investment is. So within a 3 to 5 year timeline, to expect an impact that is greater than what perhaps the secular trend is in a country, it requires quite a lot in terms of data and quite a lot in terms of implementation. So what's best for projects? Local surveys or reanalyzing other surveys? And we heard some very good things about it already. But if we think about local household surveys, or the baseline, midline, endline model that we've heard quite a bit about, you get results for the districts, it helps targeting, it helps document project results, and maybe it could also help assess impact, which of course is the ideal situation. But they're very resource intensive. Their results, as we saw, are not very different from a national survey or a subnational component of a DHS or mix. And you have large uncertainty. It's very hard to show impact. It really needs very large samples, unless you have a very huge change in a very short period of time. Then national surveys, of course, have the great thing. They have high quality results and legitimacy. The data sets and reports are widely available. They're used for trend assessments, but they only go down to province or regional level. And the standard indicators are only there. There are no specific things that perhaps are the focus of the project. And disaggregation for adolescents and other subpopulations is often limited. So in our project, we're digging deeper into the national survey data to try to see how far can you go with identifying adolescents who are left behind. And there is actually a forthcoming supplement of BMC Reproductive Health, which has 6 of those papers: Adolescent and Sexual Reproductive Health for All, Are Inequalities Reducing? So we looked at the conventional dimension of inequality, dimensions of sex, gender, wealth quintiles, education, urban, rural, provincial, and regional level, and age. And then different topics: marriage, early sex, pregnancy and childbearing, contraceptive use among adolescents, married or not, HIV and sexual behavior, intra-partner violence. And then also not only looked at DHS, but also looked at the PMA surveys, they started off as family planning surveys, which actually conducted initially 2 surveys a year and now once a year in about 10 or so countries to detect rapid change in family planning, but it's also used for several other reproductive health indicators. And what we really found is that, I think one can do a lot with these data. The sampling errors get larger as we go to subnational level. The provincial estimates particularly get more unstable. So one sort of 4 or 5 categories of disaggregation is about the maximum one can do for adolescent sexual reproductive health. But there's a lot in there. So our conclusions were really, do more with national surveys, and sort of we're more hesitant about local surveys. But I'll have a few suggestions on that at the end. And I think Antu asked about innovations, and I think that time is there for innovations. But it's possible with national surveys to obtain detailed and robust information on inequalities, even though the sampling errors are large, because you do triple disaggregation by sex, by age, and then socioeconomic. But we were surprised how robust they were. Then the provincial and regional estimates are possible, but further disaggregation at that level makes it unstable. Local district surveys are unlikely to add much information that's different from what can be obtained through national surveys. I've done dozens of those. I've been a great advocate of those, But in fact, perhaps, it was not worth the effort. Even just think about, all these procedures that are not in place, like so routine analysis, archiving of data, etc. It's a huge effort. So subnational variation, it's not easily captured in local district surveys, but I think we have to keep in mind that with the sort of crude information on where to target or what to do, it's not likely to change program priorities through a local survey. It's definitely not very likely to be able to document impact that is statistically significant, more so than, say, good program monitoring, and I would say complemented by in-depth qualitative research with the national survey data. So I think there are some exceptions though. And we've worked with Plan International in our collaborative, which I forgot to mention at the beginning, and they're very keen on male involvement. And so they actually started to include modules and more questions on male involvement. So I think that if there is really a need for that, and there's the resources are there to invest big time, and then I mean just also kind of in a research way that one can evaluate what one measures and one can review all the tools that are out there. So male involvement was an example. Another area that they've really invested in is female empowerment. And I think we're looking at some of the results, and some things may be useful, but one always has to ask, to what extent is it going to change my program, and eventually can I show impact? And I think that we have to be very modest. Innovations in surveys are possible. When one does invest in a survey, I think the topics may be different. We are also, as part of this project, we included questions about the health of adolescents as part of the birth history, and children 5 to 14 years, things that the DHS doesn't do. And I think these are things that, if that is a focus of a project, surveys can be very useful. I think facility assessments, of course, is another part that is critical, and many NGOs do it. They can become more useful, perhaps, if they're used in a very light touch way, as is done now with COVID, with quarterly telephone surveys. And then also the sort of DHIS2, so the health facility data. Now, suddenly, everybody's interested in these data to see if the continuation of essential services is what we want it to be in the time of COVID. But these data, of course, can also be very useful and will get better and better in the future, is my sort of optimistic conclusion. Lastly, I think we have quite a bit of experience with the qualitative research complementing the survey. So for instance, the work that Elzeby did as part of our collaborative on peer ethnographic review. And I think the combination make a very powerful set of data to plan, monitor, and evaluate programs on. So let me stop there. I hope I didn't talk too much, but I think it's a great topic, and I think it's kind of interesting how the two collaboratives, without too much interaction, arrived at the same conclusion. Thank you.
Thank you, Thies, Milena, and Peter, for your many insightful thoughts on what is really a sector-wide topic that we hope to keep on engaging with. I mean, the collaboratives have found some insights, but we really do want this opportunity here with all of you participants to be a point of conversation. So feel free to add your questions into the chat box. Feel free to use the hand raising option, and then we will know to have you unmute yourself. But if I can get the dialogue started, I think there were some really great points, Thies, that you ended on, including the fact that there's a lot more interest in the understanding of data and whether there's continuation of services throughout COVID. So COVID is really the question we have now. How has COVID-19 affected the quality and reliability of publicly available data? And how can we navigate this challenge, or, the opportunities that are there? Well, we already have some really great questions in here, but we will definitely allow ourselves to get to that. So with that, I pose that question over to you, maybe let's say Peter first, and then we can come back.
Sure. Well, I think the kind of obvious, easy answer, I'll let Tis give a more nuanced answer, but if the surveys aren't happening because of COVID, then there's no data to be publicly available. And I don't know what the plans are with DHS, but I know Mix is starting with phone-based interviews, and I just was at a webinar a week or two ago where they were showing results from Mongolia, which has something like 95% households have a cell phone, and they did phone-based interviews with some success, with a high response rate. You can get nationally random because you're not restricted to cluster sampling. So that may be the future, but even beyond COVID, because if you can get it working, it's cheaper, easier quality control, easier to get random sampling. Of course, restricted to countries with very high cell phone coverage. That's all from me.
Yes.
I can go next.
Yeah.
I think this point that Peter brought, it's really interesting. And also the fact that like when you're doing phone interviews, you can also include the hard to reach locations that sometimes are excluded from when in-person surveys. And another point is the fact that when you're doing interviews by phone, they need to be shorter, right? You can do an interview that's, I don't know how long DHS interviews are. I would guess more than 1 or 2 hours. But when you're doing it over the phone, like you can do something that is as long as an in-person interview. And I think that somehow that can affect the validity of the data, but in the sense that the length of the interview can impact how well the participant will answer the question, right? So interviews, I think in the Mix Plus that Peter mentioned took about 15 to 25 minutes in comparison to face-to-face interviews that can take, I don't know, 1 to 2 hours. I think in one side you're limited by time and to the questions you will like you make, but at the same time, I think it's a good opportunity to think, do you really want to ask, like, do you need a 2-hour survey? I think it's a good opportunity to think about that. And also the fact that we know we have a lot of data that it's underused. So maybe the pandemic might be a good opportunity to think about that as well.
Maybe just to add, so yeah, come February 2020, boom, no more DHS, no more Mix. And we're so dependent on those surveys. I'm also wondering sometimes, suppose USAID pulls out of DHS. I've worked for DHS in the 90s, but those surveys are entirely dependent on that donor, even though others chip in. So I think mobile phone surveys is a great addition. I don't think it can ever replace face-to-face surveys in populations where levels of education are not that high, and also where mortality levels are high. Mongolia is a very low mortality country. But for coverage of interventions, perhaps, I would say though, that in NGO settings, what is happening with the health facility data is a very viable alternative. And so, and I think it's one of the questions in the chat box as well. If you say, my focus was on, say, family planning or delivery care and coverage, and did it increase during the project time or not? And if you look at the survey, they're usually 3 to 5 year intervals where you get an estimate of coverage. So it's actually all about before your project started. But if one looks at the continuous routine health information systems that come from the health facility data, with a reasonable estimate of coverage, so meaning you need the target population and you need the numbers to be correct that come from the facilities, you can actually do a reasonable estimate of coverage and the trend over time. And we've been doing this now with more than 10 countries, and I'm increasingly encouraged by what I see. It is possible with a good effort. So I think there's an alternative. And I think because of COVID, everybody seems to be interested now suddenly in these data that were considered very poor quality before. So we'll hope that will translate in better investment in this area.
Oh, fantastic. No, thank you. I think there are definitely some hopeful opportunities as wild as this last year has been. Maybe it will actually push us to take advantage of what we've had so far all these years. So I do want to point to a question, maybe it's more directed at Peter. So 2 questions, Peter. I think we want a better maybe understanding of the linkage in the first graph that you showed us.
Mm-hmm.
So maybe Milena, it would be helpful to pull that graph up if you'd like. So essentially in that graph, it showed large differences between NGO and DHS data, and that the conclusion is that NGO surveys would not provide additional or useful information above DHS. Is that the conclusion, or would you like to add more to it?
Sure. And the question disappeared when the slide went up, but okay, where to go?
The second one?
There it is. Yeah, no, I'm good. So first, it's not necessarily that they don't provide additional useful information, but there is a cost benefit, right? The amount of time and resources put into collecting the data, the burden on the respondents, these are usually, in MNCH household surveys, they're usually young mothers with a young child. And if a survey, the typical attitude is, well, we're there, let's ask them everything. So the survey ends up going 2 hours or however long. It's a burden on the respondent. So is it worth that that effort for what you get out of it? And then the other dimension to consider is why do you collect baseline data? If it's for establishing your program interventions, trying to identify what the key areas are. And I would ask, consider, do you actually not know what the problem areas are? Do you actually need to do a household survey? If, whatever your region where you work most often, can you think off the top of your head, if whatever, healthcare, births and health facilities, or iron supplementation, or child vaccination, whatever, think, is it going to be so low that it's not a public health problem, that it doesn't require a public health intervention? Because for whether something needs a public health level intervention, it doesn't matter whether the baseline level is 40% or 60%. That's something that's can only be addressed through public health. So for setting that sort of goal, or that sort of planning, there's a very wide range of tolerance, a very high tolerance for knowing exactly what the baseline conditions are. And then if your objective is you want to use baseline so you can do a baseline inline comparison, then there's I have a 2-part answer. First is, it's about a couple of years ago, just when we started working on this, I started reading literature coming out on how you can more efficiently monitor an intervention through not doing a baseline, instead put all your resources into a properly randomized end-line evaluation, where you have comparison villages who are randomly selected. And so if that is the objective, there's a better way to do it than a simple, than a baseline inline comparison. And then for, we didn't consult the donors. I don't know if TEAS did, but I think there might then be those working in this area need to help educate the donors on what on what the burdens, the costs are, the burdens to the respondents, and what you can actually tell from it. And with a typical baseline end-line evaluation, without being able to properly control for secular changes and for measurement error and for other random factors that we don't know, we really don't do that good of a job of measuring the impact of NGO interventions anyways. So putting all those together, I think we can do without it. I mean, most of my work is actually doing baseline assessment. So I think, I appreciate that there is a lot you can get out of them. So maybe I shouldn't be saying, let's do away with them entirely, but rather how can you direct your resources differently so that instead of asking, we're doing these large or 500 household surveys, are there on everything, focus on what you really don't know and what you really need to pin down, put the resources there, rather than, what is the percent of women who give birth in health facilities? You know that it's high. So instead, can you, through qualitative work, look at why they don't give birth in health facilities and what sort of interventions would be effective, put the resources there. Rather, so that's my answer to that one. Should I see another question, or is that for Catherine, if that answers your question? I guess before moving on, I should stop talking and let there be follow-up to that.
Hi, so this is Catherine from Save the Children Canada. Thanks, Peter, and thank you to all the speakers for a really interesting presentation, and also I think really key reflection points for all of us in the sector. Definitely, I mean, it's interesting to see the results and the suggestions being made by the panel, and speaking sort of from a very practical lens on the work that we do, and certainly in the NGO surveys that we run in our projects, they are very targeted and focused, and we also don't survey uniquely for public health indicators, but are often looking at those social components. I think the realities of the results-based management and accountability that donors have usually mean we need to quantify in addition to doing qualitative work. So even if it is a social norm sort of driven piece of this puzzle, we're often asked to have hard numbers behind that as much as we can. So that's sort of the sticking point that I was trying to get at with the questions, and look maybe sort of, yes, at the complementarity, but the point is well taken that there is data here that we can and should be looking at. So thank you.
Thanks, Catherine. Yeah, it is. I know it's easier for me to answer here when I'm not responding to a program officer asking me for those specific estimates. So I know that there's different challenges. Thanks.
Yes, please go for it.
No, if I may just may come in, because I think this is the sort of key issue that that you're dealing with in these things. Because so on the one hand, there's this expectation that you can quantify these indicators of interest that are also central in the projects, and actually even show impact, and it's very understandable that a donor wants that kind of information in addition to, say, qualitative information on gender issues or some health indicators. So I think that's well understood. But I think at the same time we have to realize that surveys are complicated instruments that are aiming to get your population prevalence of a certain behavior or coverage or a certain norm. And it may be useful, a rapid knowledge, attitude, practices, behavior survey may be useful to underpin some of the qualitative findings. And for some areas, it may actually be very useful. I think where we're hesitant is when it gets to first of all, indicators that are the same as in the demographic and health survey. And I think the comparison that Peter showed shows you cannot really distinguish that. I think also from the survey, with these relatively small surveys in districts, and to document changes over time is even more difficult. But you can use them, I think, for new topics. But the big question is really, is establishing the population prevalence of the behavior or coverage or whatever, is that the real issue that will drive the program and the project? And I think that's where I'd like to hear examples from, say, NGO surveys where they've really changed the program implementation and targeting, where the survey findings were there fast, because they have to be fast, and where they actually led to major course corrections in what you were going to do. And the second question is then really, is there any evidence where you can actually show impact and attribute it to the project? Because that's what evaluation is all about. And I think that, so I think we understand that donors ask for this kind of information, but at the same time, I think we should not shy away from having the discussion on what is the most efficient and effective way for the project to be as effective as possible based on data.
Thank you. I think this is a very, very big conversation, and I'm really excited that we're digging deep into it. I do want to allow Sophia to unmute herself as you have a question as well.
Actually, I just wanted to share our experience in this, and thank you so much for your presentations. And it was super useful to see the results of your work as well as your recommendations and reflections. I'm from Aga Khan Foundation Canada. We typically do baseline and line surveys. But for one of our large programs in Afghanistan, which was a 5-year project. At the very beginning of the project, all the kind of key stakeholders, including the Ministry of Public Health, especially the Ministry of Public Health, were pushing for using DHS for a baseline data. And this is because it was happening around the same time that we needed it. And the project steering committee, which consisted of Global Affairs Canada, as well as another donor, all agreed to this approach. And when we came to the end of the project, basically the next DHS that was planned got delayed, and there was no subsequent DHS survey near the end of the project. And so we were kind of stuck at the end because most of our indicators were kind of using the DHS as the source of data. So that's where things got tricky, and that's kind of aligned with Catherine's earlier point about the kind of cycles within the project timeline cycles versus when we're expecting DHS or other secondary source data. But our workaround was using doing an analysis of secondary data that's also available through the National Health Management Information System, and also complementing that with a qualitative study. But just to let you know that it was something that was accepted by Global Affairs at that time.
That's amazing. Sophia, thank you for that reflection. I think that ties really nicely into a question we have as well around what are the pitfalls or common mistakes in cultivating DHS data for information of local specific target groups and needs? And then if we can follow that up with what and how can qualitative data collection be conducted to complement the DHS data? So therefore, to ensure that results can be attributed within the limited time frame of 4 to 5 years. So I see a mix of how effectively can we integrate qualitative data, because we see a lot of interest here. So Thies, I believe you can maybe start off if you'd like.
Sure. Yeah, I think the issue with the mistakes with DHS could be that you over-interpret, over-disaggregate. So you're bringing it too local, your sampling error gets used, and it gets huge, and that's what might be a misleading finding. But I think generally, if you stick to the core principles, and Milena showed the stat compiler, it's so quick and easy, and really to go into analysis yourself takes a lot of time. I use it all the time, to really put quick things together, and you can go deeper for a project. But I think that's so I would definitely try to stick to what's out there. Now, I don't know, I think Elsie is on the line. So I maybe, she could come in and say a little bit about how you can use qualitative data to complement quantitative data, like we've tried in Tanzania. Elsie, are you?
I'm here. Hi, everyone. Yeah, so I think how you can use qualitative data best is always going to depend on what your questions are, right? So there are different ways to collect information. Focus group discussions and interviews are used fairly widely, also wildly sometimes, but I mean widely, for people to help understand what those DHS numbers and what the statistics actually mean in that specific context. What are the contributing factors? Why do the statistics look the way they look? And then help people understand where you can intervene. In later stages, it also helps you understand how people have been interacting with your program, and where the possible changes are. So those have been used. What we tried to do was go a little bit further than that, and use a peer ethnography or peer research approach that really tried to get a little bit more in depth than what you get with interviews and focus groups. And I think that really contributes something valuable in understanding how different factors in a particular context shape the statistics, how they structure everyday life, and really where you can intervene and contribute to project outcomes. So I think it made a very valuable contribution, and I'm happy to talk more to people about it. But I think, Antu, if people want to sign in 2 weeks for our next workshop on mixed methods on how to bring these things together, I'll be happy to provide more information. Thank you.
Yes, we have an entire hour digging deep into mixed methods. So actually, thank you so much, Melody, for dropping the link there to register if you would like. Registration is open right now. And Elsa and her lab, which includes Tisa's lab, but also we will have another one of our labs with Nutrition International, Campbell Collaboration, and the University of Toronto speaking as well to this topic. So we encourage you to join us. In that vein, I think there's another question that I can ask here. And I am just trying to find it. But with respect to, I think it was polling data. So any thoughts on the utility of polling booth surveys instead of large-scale household surveys, particularly for behavior-related indicators? I think I can pass that question to Peter, if you would like to start, and then Milena, if you'd like to jump in at all.
Is a polling booth survey a survey that takes place during an election or something? Well, I don't know what a polling booth survey is.
I can jump in. So
thanks, Tisa.
A polling booth survey is a survey methodology that's used to solicit sensitive information, sexual behavior, substance abuse, all sorts of things. So it's done in a way that the respondent is, totally comfortable, and that nobody, like a face-to-face interview, this sort of thing, shall I say this or not? So it's shown to be a method that, gives you more truthful responses. So actually in Monza, we have another experience, part of our lab, is that and I think a lot of you in the NGO world are doing this as well, is basically using tablets with, but audio, the questions are asked by, through an audio, and the respondent basically just sits there with a tablet. Whether or not this leads to, much more truthful responses is still, I think the judge is still out. I think there's definitely literature that shows that this archaic method gives you better results for some indicators. We also tried other things in our work around, for instance, best friend methods or community methods, so indirect ways of trying to solicit responses on behaviors that are core to your program. So I think polling booth surveys definitely are very useful. I think the use of modern technology also will help us with this. But it's still getting adolescents to report on sexual behavior or substance abuse remains a challenge. But I think many studies have shown in the past that the data were just not very good. There's some reflections that maybe Elsevier wants to chip in again because she's been leading the project.
I think there definitely is a lot of evidence saying that ACASI, so audio-assisted surveys, do give you more truthful results, and definitely our NGO partners have had great success with it. In our particular experience, I think what the adolescents told us was that they did feel there was a greater level of confidence in their privacy and the confidentiality of their results. But we couldn't really see a difference between the results we got and the results we got from the survey. Now, the area where we implemented is very unique in the sense that these people have been part of a cohort for a very long time. And so answering survey questions and questions about their behavior might not be, excuse me, quite as stressful for them. So we don't really know. So there is evidence, but I think we need to do a little bit more work on seeing exactly what it can tell us and how it can be useful. I think the only reason we had decided not to do something like a polling booth survey was just that we would have had to be very directed in the questions that we asked. So it would have limited the number of questions we could ask. And one of the things that we wanted to look at in the lab was were there different ways of questions, the indirect ways that Ties mentioned. So asking about the best friend or community report, and we also used vignettes, could elicit the same kind of information. And so we steered away from that. But based on our results, the indirect questions definitely offer quite a bit of opportunities to learn about the population and the behaviors taking place. So I do think there is a lot of opportunity there. Thanks.
Wow, thank you. I think that this has been such a fruitful discussion. I'm really excited to dig deeper into the future learning opportunities that we have upcoming. So March 11th, we have the 365 days of a pandemic. It'll be almost 1 year since then. And at that point, we will be talking further about virtual practice implications for monitoring and evaluation. And of course, with Elsevier on the line, you've heard her dig deep into mixed methods and where this project has gone. So feel free to sign up for March 17th as well. The links are in the chat box. Those are some future learning opportunities to continue what is truly more critical dialogues that we need. This knowledge exchange, I have found it really fruitful today, and I hope that you have as well. So I'd just like to acknowledge, over to the next slide, we just want to thank you all for taking an hour today of your time and joining us. I gratefully acknowledge the discussants today, Peter, Milena, and Ties. We also gratefully acknowledge the support of Global Affairs Canada for allowing and enabling this environment for innovation within data monitoring and evaluation. So this is their contact information. Feel free to get in touch with them. And if you have any questions about the collaborative as well, that's our email there. We hope to see you all in different learning points. But till then, take care, and many, many thanks for being with us here today. So,
Thank you.
Thank you.
Thank you, Antu. Bye.
Bye, everybody.
Thanks.